We're like, ooh, AI algorithm, right? So it's easy to get new shiny thing syndrome. And then realize that if you're not good at treating sepsis, it doesn't matter how good you are at diagnosing sepsis. And so we then focused our care then on treating it and creating a bunch of tools to help people standardize the treatment. And then by doing that, we then created the bottom layer of the stack that you would need then to start to diagnose it. We use the same UI system of alerts and things like that we had already enculturated for treatment into diagnosis. And then you built that and then we iterated on the model.
Hello, everyone, and welcome to another episode of our podcast. Today, I'm speaking with Dr. Jason Hill, Innovation Officer at Ochsner Health. Jason is an internal medicine doctor by training. He previously served as the Associate Clinical Informatics Officer at Ochsner, where he led incredible projects. System-wide transitions of care, artificial intelligence, decision support, adoption of voice recognition, predictive analytics, and so much more. Jason really sits at the nexus of technology and clinical, where they come together. So I'm so excited to speak with you, Jason. Thanks for chatting with me today.
Yeah, thanks so much for having me here, Ohad. This is a cool opportunity and I always relish the opportunity to talk about technology and healthcare. It's a personal passion of mine. So thank you for having me on.
Mine as well. So really to kick things off today, could you tell us a bit more about yourself?
Yeah, sure. So interesting about, when you say the doctors going into technology, what kind of doctor does that? Because generally most doctors are not super technology friendly. I was a nerd way before I was a doctor. So I'm an engineer in college. My wife is also an engineer. My father is an engineer. And my brother's a research scientist.
So you must be a big disappointment to your parents. Usually it's the other way around.
Huge. Yeah. So I had kind of a personal health event happen to me when I was in college and was on track to was going to do a PhD in biomedical engineering on tissue engineering. And had a medical medical crisis happen to me. And I felt my calling in medicine after that and switched out, changed my degree track, took the MCAT, and went to medical school. And so I think that really set my mind that healthcare is where I wanted to spend the rest of my life. But it became quickly evident, too, that as an engineer, it's hard to see systems without seeing the brokenness between the systems and wanting to fix them. And I started noticing that. And in particular, in the early 20-teens, when electronic health records were becoming commonplace, that people noticed that I had an affinity for doing this kind of stuff. So the company that I worked for, at that point in time, I was actually a chief resident, and they had told me that they wanted me to write all these order sets for this new company called Epic that was going to come and do our electronic health record. And so I did that. And then when I got out of residency and went into the real world, then the company I work for now, Ochsner, then found out, oh, he knows how to design order sets and stuff for these electronic health records. And I started doing Epic implementations, and we did a grand total of 45 Epic implementations. The hospital that I worked at was the first hospital in the entire state of Louisiana to go live with Epic. At Ochsner, it was also the first hospital to become HIMSS Stage 7. And when I got there at that hospital 1 year prior, it was paper records. They had people running around, putting numbers into charts with the lab. I went from a really nice system in Houston to this system, and I was like, oh my gosh, what have I done?
I'm amazed you don't have more gray hair than you do, having done 45 Epic implementations from full paper to full EHR. Wow, there's a lot to unpack there, but really interesting because you're spot on, Jason. Many of my guests started with a much more clinical orientation and then kind of moved to the dark side and got interested in technology and integrated that into their practice. And you're coming at it as a technologist who became interested in clinical and ultimately found a way to fuse the two. And really interesting to hear that, the kind of the backdrop for you coming into that is the adoption of electronic health records, which is, such a material change. And in many ways, I think still controversial in terms of did it completely change the practice of medicine and throw it in a completely different direction as a result of all the incentives at the time to drive meaningful use of an EHR. So we'll come back to that point, but I'm just fascinated by that journey. And so now you've done these implementations. You're the associate, I think, medical informatics officer at Ochsner. Is that right?
Yep. Yeah. So then we got through implementations, and then very quickly people were saying we need to do this better or do that better, and can we figure out how to do this? And I started working alongside the CMIO then to start working on those projects, and rose up through the ranks and kind of became the head of the clinical decision support committee. Started working on developing novel predictive models for things, and then purveyed there quickly into not quickly, but probably over the next couple of years, watching AI come to the forefront of non-medicine. So I still remember when the attention paper came out. It was super exciting in the nerd world. And the ability for computers to actually understand human language I recognize that very early as a sea change, particularly in medicine, where so much of our information is stuck in language and not in discrete fields where databases can read them well. And so we started working on that early on, and then the pandemic happened and shifted everybody's attention away from looking at AI and how to operationalize it, much more to like trying to survive. And out of that came many interesting innovations. I think it moved in a good way and moved our virtual care strategy like a decade ahead of where it would have gone had COVID not happened. So we went from, and I'll tell you personally, in the hospital I worked for. So I was also a hospital leader at that time, and we had a hospital with an ICU that was twice as many patients as the ICU could handle. So we had grown and by necessity cannibalized the operating room as part of our ICU. The ER was also part of that, was an operating ICU. And I had around 16 people, 4 of which were sick with COVID. So I had 2/3 of the providers and twice the patients, which, as you know, that doesn't take a math degree to figure out that's a bad idea. And so we had to figure out a way to make those providers actually work. So at the first, I remember going to Best Buy and buying 7 iPads and figuring out how to do voice calls through virtual, and then having the doctors round virtually. And we got to the point where we're actually able to just have a couple of doctors in the hospital for codes and rapid responses. And the vast majority of our team was able to leverage virtual rounding to see all of these extra patients. And I later did a study on it, a look at non-inferiority and the quality vet days, all that stuff was completely similar. And these were really sick people. These were people that like on a ventilator, prone, like really sick, not like just run-of-the-mill patients. Necessity is the mother of invention. And I remember that actually changed my mind as a doctor, that like you really can deliver really high-level care virtually. And that was and that then brought me into the line of, well, how then can we leverage some of those things to create what I call liquid out of solid, right? There's this physician shortage. There's no way that we have the amount of doctors to see the amount of patients, which means that we're going to have to figure out, and that shortage is not evenly distributed either, right? So if you look at Louisiana and you look at primary care, it's way worse than if you look at like orthopedics in Boston, right? And so being able to help to redistribute that, virtual care created a lot of the ways to do that. And so we thought through that, and then also team-based care and app-based care, and all of those things that we're looking at, the sort of like Shangri-La of asynchronous digital medicine, are things that Ochsner has been really in the forefront, and I've been very privileged to help to develop a lot of that work.
And that's now in your capacity as Chief Innovation Officer, kind of that transition coming out of COVID was taking on a broader responsibility for driving these innovations into clinical practice.
Yeah. And so I had the privilege of leading the innovation team for a while, and we worked on trying to understand how to bring these novel ideas and concepts and technologies into clinical practice, not just at a like little pilot level, but like we wanted to scale it to as many people as we possibly could. Mm-hmm. So our first swing at bat for that was our digital medicine program, which happened before I was the innovation officer. Dr. Milani, who really led a lot of that work, who's now at Sutter with a lot of our other team, had really pioneered a lot of that and did digital medicine before it was even like a thing. And now we've created our own custom app. We have 40,000 patients across all 50 states, managing 4 different conditions. So hypertension, diabetes, weight management, and very soon I'm going to be looking at some other cardiometabolic conditions. And spinning off in the process of spinning off that as its own separate company. So that is one way that you can help leverage like that shortage of physicians and managing care where people want it, hitting that win-win. Like, who wants to go into an office, right? Like nobody, like I don't want to go to an office as a patient. Like, I would rather just go on my phone, have my doctor see my stats and say, Hill, looks like your blood pressure is kind of bad. Let's increase your medicine. I'm going to shoot it to your pharmacy, right? But the problem is we're sort of hamstrung by this payment system that sort of incentivizes this really inefficient form of care. And so it's been a real challenge on scaling out how that works.
No, I really like that perspective on scaling. And I think I mentioned to you when we were prepping for this together, a lot of our audience are medtech entrepreneurs. And I think the challenge they often feel is that like healthcare is a bunch of snowflakes. Everyone's different, right? And like no one implementation is the same. And they're all kind of like in this POC. How do you move from that POC to scale? And I think it really does take that view of, first of all, solving the right problem, but really having a commitment from the inside of, in order to achieve the clinical effectiveness that we expect in this innovation, it's got to be at scale. It can't be limited to these edge cases, to something that's a POC for 4 years and has a published paper. Yeah, I mean, there's a lot to unpack there. Maybe let's start with just kind of the inherent challenge of kind of where innovation meets clinical. There's, how do you create the right environment for the receptivity on the clinical side? Because clinicians are incredibly busy. Like you said, they're in Louisiana and in many other places. They're so overstretched. They've got this life-saving responsibility for the patients. They have to do what's right in that context. And any kind of adoption of innovation requires change. And the thing about change is it's different. And you have to spend time and you have to learn it and you have to invest in it and you have to try to make it work. So what's your experience? Like, how do you lower that threshold, that hurdle rate for clinicians to be able to be open and receptive? And it sounds like you've got a lot of experience doing that, even from back in the days of EHRs, because that transition from paper to Epic is a painful one.
Yeah, they used to call it an Epic. They call it the Valley of Despair, which is like the 6-month post-implementation depression that hits the entire system. And everybody is so sad and everybody is so unproductive for a few months, and then you become more productive as a result of it. I think, one of the unique parts about working for a company like Ochsner is that like scaling is like Ochsner's superpower. It's one of the things that it's really good at. And it comes down really to ethos. Our chief executive officer and our chief digital officer, so Pete November and Denise Bassau, are laser focused on creating an ethos that's around innovation. They say that necessity is the mother of invention. And we live in a state that is consistently number 49 or 50th on health outcomes, right? Along with many other things. And we're also one of the poorest states. So it's not like I can go to a bunch of wealthy benefactors to figure out stuff. So we have to actually find ways that are both more cost effective and provide better health at scale. And I think that's one of the unique parts of working in a system like this, is that as a system, we realize like we have to be innovative because there's no other way to win in this area. And so I think that is one of the things that excites me. And frankly, like one of the reasons I work at Ochsner is for that reason, is that I think we have all the way from the E-team down to our frontline providers, with, obvious exceptions. There's always exceptions to everything, but cultivated a culture of innovation at Ochsner. And it's one of our core guiding principles.
I can see that, top down. Like, it sounds like you've got great leadership that is advocating for this, recognizes this isn't a set. We have no other way to take care of our population, of our people, unless we innovate. But where the rubber hits the road is usually where it gets hard, right? Because because you've got 10 different balls in the air and you only have 2 hands. So where does that kind of, when strategy translates to execution, how do you lessen that hurdle rate to really make the clinicians receptive to the change and work with them to not just realize it on a system level, which I'm sure they can buy into the big picture change that's needed, but they got a patient to deal with right now and they only have 3 minutes to do it.
Yep. I mean, I think I call it scale hell. That's what I call it. So it's always hell and it's always hard, right? And you always figure out things that you didn't really know in the beginning, right? Like I remember doing this with our sepsis algorithm, right? So we did a predictive model for sepsis. We designed it from Epic, got it. It's gotten a lot of bad press since then. But quite frankly, I think the bad press is undeserved. The algorithm works good. What we found was that we weren't good at treating sepsis. Like, even if we figured out who was septic, like, we couldn't do all of the things that needed to be done to treat them in the time. Like, And so we focused on the wrong thing. We're like, ooh, AI algorithm, right? So it's easy to get new shiny thing syndrome. And then realize that if you're not good at treating sepsis, it doesn't matter how good you are at diagnosing sepsis. And so we then focused our care then on treating it and creating a bunch of tools to help people standardize the treatment. And then by doing that, we then created the bottom layer of the stack that you would need then to start to diagnose it. People started, we used the same UI system of alerts and things like that we had already enculturated for treatment into diagnosis. And then you built that and then we iterated on the model. And so I think the problem is that a lot of times when you're approaching a technology problem, it's not a technology problem, right? Like, or you approach it like, oh, have this vendor do this thing. You have to look at the whole workflow. Another great example is our in-basket. So we had a huge in-basket problem. And we're like, well, let's employ AI to help us to give our doctors an easier way to reply back. Well, the doctor said, like, I don't want to reply back. I just don't want as many messages. And so we fixed the wrong problem, right? So what we tried to do, instead of trying to give doctors a nice way to put back, we created a way for the patients to answer their own questions without having to ask the doctor, right? We created ways for a patient to then go into a portal. If they want a refill, just click a button, you get a refill and then we created a few pharmacists to oversee that as a system, right? And so we have to make sure that when you're doing these things, you're always looking, oh gosh, the doctors are, and believe me, I'm a doctor, so I can say this. Every doctor is their own special snowflake, not just every health system. Like every one of us have our own little way of doing things. But if you can really get to the heart of the problem, and it's almost never what you think it is, then you can start to solve it. Once we started thinking of, well, what does the patient want? What does the doctor want? And where's that middle ground in the middle there that we can give the patient what they want and give the doctor what they want. Let's build that thing up, right? Whereas in sepsis is like, what do we need? Less people septic. Well, fixing AI will help us diagnose it, but it won't let us less people dying from sepsis, right? You'll just recognize it more and then treat it less. And so
I really love both of those examples of how to bring to life this concept of like, make sure you're solving the right problem. And especially the one with a clinician, email inbox of like, actually, instead of a better mousetrap to get them to respond to email, decrease the volume of inbound requests by empowering the patients with more self-serve capabilities. And so maybe kind of just interim summary of what I hear. I think it's like you talked about kind of where clinical and innovation meet. So you said, number one, from the top down, you have to have the right strategy that's driven by necessity, recognizing that the broader challenges that healthcare faces in Louisiana, in the US, in Canada, globally, is we're kind of supply and demand problem, and we have to innovate. We have to continue to get better. And that starts with top-down vision and a commitment to seeing that through and scaling it. Sounds like number two, making sure you're solving the right problem. And through that, what I heard from you is make sure you're understanding what the stakeholders need. The problem is actually made up of different stakeholders, and they have different interests. The patient has a different interest than the clinician, and you want to make sure that both are served. And if you understand them, you can make sure you're solving the right problem. And then the third thing I heard is think about the integrated workflow, the end-to-end solution. Like in the example of sepsis, the fact that you're increasing a diagnostic capability, it has to be supported by a better treatment pathway, by more efficacy downstream of now that you've diagnosed that condition. Are those kind of three fair takeaways from what you've described?
absolutely. And we hear a lot of vendors that come to us with like, oh, let's get these diagnostic solutions. And the one just recently that was saying like, listen, we can actually automate diagnosis of depression for your whole system. And I was like, I don't know if you know this, but we have a 12-month backlog on people to see a psychiatrist. Do you really want to increase that? When technologists are thinking through solutions, you really need to think through what's the constraint point in that workflow? What's the pain point in that workflow? And what would happen if I were to make this part better down here? Like, it's really important to think that.
So far, though, we've thought of everything through a clinical lens and an efficiency lens. Unfortunately, the world we live in, there's also a reimbursement lens. And this is another place where the rubber hits the road, is who gets paid and for what. Because I'll say for my company, we're a handheld ultrasound company. I think we are solving the right problem when we think about, for example, how to move imaging from the basement of the hospital from the hub into the spoke, right? To empower better decision-making at the point of care, avoid big backlog in the ED when you can diagnose something, triage it in the ward, in the clinic, maybe even in the home using AI. However, that only works in a system where you're measuring the overall efficiency and you're reimbursed or monetarily compensated for the avoidance. In much of our world that is still fee-for-service driven, without a fee code, it's very hard to convince a primary care doctor to take an extra 3 minutes to look at your gallbladder with their ultrasound. If they were really worried about your gallbladder, they have zero incentive to do it themselves. So what would they do? They'd refer you to radiology, where you're waiting for 6 months to get a sonographer to image your abdomen. And so where does that fit in? Like, let's say we solve problems 1, 2, and 3. We've got this top-down vision. We're solving the right problems. We've built an end-to-end workflow. But how do we align that to the economic models as they principally stand today?
You've got to get creative with that. And I think that, we could talk ad nauseum about economic models for healthcare. And I've been on a couple of those talks and they almost never end well, especially in the United States. But I think the key for that is that thinking about a creative way, and I'll give you an example, and I think it's a good example, the one that you teed up, which is looking at point of care ultrasound or radiology tests, right? So let's say, for example, I'm a primary care doctor, right? I got 15 patients to see in a day. One of my patients has got a suspicious mass on their thyroid, right? I want to figure out I want to send them to an endocrinologist. Well, then they go to the endocrinologist. The endocrinologist does all the testing, and then the endocrinologist sets them up for a thyroid ultrasound, right? So then they go to the thyroid ultrasound. Then they have to go back to the endocrinologist with the results of the thyroid ultrasound. Did we get a biopsy? If we go to the biopsy, we go back to the thyroid ultrasound again and then do an ultrasound with biopsy, right? And so what would happen if you were to try to constrain some of those points? And we've been working on some of that with a colleague of mine, Ted Hudspeth, and he's been doing work on e-consults. And what e-consults are, it's a way to get reimbursed for asking a question to a specialist. And the specialist doesn't need to see that patient. So you're basically, as a primary care doctor, teeing up a clinical vignette, shooting it over to the specialist. And that specialist can then take that up and say, ooh, you know what? This person looks like they might have X, Y, and Z. Let's get these labs done before they get to my office. Or that specialist be like, oh, actually, you're sending this to the wrong person. Let me send this over to this specialist, right? And so what you find is that backlog of work, that now the specialist doesn't have to actually see those patients in the clinic. They can actually spend just a couple of minutes working on 4 or 5 or 6 referrals, and there's reimbursement for e-consults. And so like those areas are areas where we're very heavily doubling down. And on top of that, it helps to educate the primary care doctor, right? So I'm not just handing off that person to another person, right? That person's actually giving me actionable information coming from a specialist in my field that can then, for the next person that comes in for a thyroid nodule, I'm like, let me make sure I got these things ordered, right? And so it creates this sort of virtuous cycle, and where people do get, and you got to be creative about that. And then we've had to think through, like, well, what if all of our specialist days are spent answering e-consults? That's not good, right? So there's a balance that you have to reach there, where you can have them spend some time doing that. But every doctor has moments in the day where their patients don't show up to clinic. And we create, like, these kind of things can create like their own gig economy, where you could have doctors. We have one primary care doctor that's just super efficient and does like 30% of the e-visit work for our entire system. E-visit's another thing we use, where a patient actually says, hey, I'm having a cough and a runny nose. Do I really need to come into the clinic and see you? Or can I just answer some questions that make sure I don't have anything serious and you can give me some antibiotics, right? Or give me something, right? To make sure I don't have COVID.
And your point, though, Jason, is that this works with the e-consults, for example. It works in a fee-for-service environment. You don't have to complete the transition to value-based care, because you're aligning incentives now for the most efficient tool for the job, the best triage, the right specialist, not wasting time waiting 6 months for the endocrinologist, only to find out you didn't need to see me, you've got something else.
Exactly. You're compressing all that, right? And even in a fee-for-service world, that works, because now the endocrinologist is seeing only the complex people, which is what they get really well reimbursed for. The primary care doctor feels comfortable treating some of those less complex people now, so they can keep them in their clinic, which is what the patient wants and the doctor wants. And now if the patient does have something bad, like, all of those timelines get compressed so that we can get those things done quicker. And so that meets both the financial goals, the quality goals, and the access goals of our system, because we always struggle for access.
I love that. And I think there's another element here, which is that, we're really enabling clinicians to operate at the full scope of their practice. by giving them the framework and also the right tools. Like I often think about with handheld ultrasound, right? Where, as a primary care doctor, if you could diagnose that thyroid and basically decide based on that, even if you have to beam the image to the endocrinologist to consult, avoid that ping pong, you're now empowered to get a better care pathway, maybe send them straight to biopsy at the IR lab, or maybe even do the biopsy yourself under image guidance. And so
Yeah.
I think that's a really important aspect. We see that a lot, Jason, in non-clinician roles, like really adoption with nurses, nurse practitioners, physician assistants, who are now really expanding their scope of practice, enabling often patients to remain in the community without having to leave to go see a doctor, to go see a specialist, by giving them better tools and maybe, to your point, also better reimbursement models, better workflow to make more informed decisions at the point of care.
Yeah. I think those are all ways that we're going to have to think through how we democratize the knowledge base of medicine, right? Like how we're going to be able to do it without having to ration care, without having to deny care. We got to create a more efficient model. And that's the imperative I see in healthcare. Like there's no way that I'm going to be able to treat all the patients that I need to treat 10 years from now. It's impossible. So even if we've hired all the nurse practitioners and PAs in the world, we have to figure out a way to create a team dynamic that allows people to see the right person and leverages that person as much as you possibly can with the right information. And that's one of the beautiful things about artificial intelligence, right? I took a course in AI at MIT. You know how I took that course? I went on YouTube. With AI now, you can have the world's best course, the world's best professors teaching you. And you can ask them questions. You can go into their office and chat with them for a few hours, and they will meet you at your level because you now have the ability to democratize information. And I think that's a really powerful tool that we don't always think about when we're looking at artificial intelligence.
Can we maybe take that a step further, be more provocative? Could we take it? We talked about the clinician shortage, whether it's a physician, a specialist, or NPPA. What about empowering the patients to do more using AI? Like when I think about handheld ultrasound, again, the form factor keeps getting smaller. I want to take it to the next level. I want patients scanning themselves. I understand that the FDA is going to be worried about the patient self-diagnosing, but with AI, we can make it much more binary, right? The AI can be a yes/no machine to say, are you retaining fluid with your congestive heart failure as you're imaging yourself? Do you need to go to the ER? Is your baby, just because you didn't feel the baby kicking, could you do a quick exam to know fetal heart rate is good, placental position is good, not in breach, and the AI spits that out, not maybe dissimilar to what we've seen Apple Watch do with atrial fibrillation. And so do you think that could be the next forefront of AI helps us take more med device, more decision-making to the home?
I definitely think that. I think this is a good example that I'll show you a device here that I have.
Is that TytoCare?
It is. It's Tyto.
I know TytoCare. I'm an early investor in TytoCare.
So Tyto is a very interesting company in that they've got an otoscope that can look and identify what an eardrum looks like.
Right.
We're working on a project right now with nasal endoscopy, which Dr. Ed McCool, who's one of our otolaryngologists, has created one of the world's largest database of what the inside of people's noses look like. And he's not doing that to make otolaryngologists better at their job. He's doing that so he can make a device that a patient can then look in their own nose if they need it and be able to see if they've got a polyp there or what's going on. And I think with the advent of AI, Vision AI is a huge tool in this. Being able to interpret squiggly lines is what a lot of doctors have made their whole career around, EKGs, EEGs, right? But what if you got the best EEG guy at Mayo in the world, and he then wrote the algorithm, and then that algorithm could then be used by anybody with just putting a hat on, right? So those are the promise of this. Like you really have the ability now to recognize images and recognize things in a deep way that you've never had before. So I love the idea. We tried this in Innovation Ochsner, doing work we had an FDA approved button for looking at COPD effectiveness. And we also did work with a pillow done with Withings to look at heart failure. And you can think of this kind of stuff as like, with the pillow would detect heart failure before you even felt you had it. And it could then, you could then alert you, hey, you need to take more Lasix. And I think that's where I see healthcare going. It's going to be more into self-effectiveness, self-care, and less into this sort of like paternalistic system of like, I have to go to my doctor and he has to tell me exactly what I do, because engagement is what makes people healthier, right? Like if I'm just listening to what the doctor says and I'm not thinking for myself or thinking about my healthcare, most of the problems that kill us all as Americans are decisions we make. All based on decisions. We're not exercising, we're not eating the right food, we're not taking our medicine. All of those things are decisions that we make every single day. And that's why we have a behavioral scientist on our team. We understand that by influencing people's behavior, you influence people's healthcare. It is a direct association. I think like med tech companies don't always realize that. They're so focused on trying to influence doctors. But I think that the more powerful discourse here is how can we influence patients to take care of their own hands?
Give them better tools, more informed. And then your point is they become from being a renter where like the landlord's just saying, do this, do that, even though I'm actually the owner, you're really empowered to act and now you're engaged because you know more and you're part of the process. We still have to get through the FDA. I guess the FDA has concerns, right? That in order to do that, you really have to create devices and machines and tools that are safe and effective to use, that you're not creating the risk of patient self-diagnosing. But I mean, I think that's part of this broader journey, like your point around AI and doing the AI course at MIT, information is so pervasive. It's so much more accessible. Like it's a fallacy to believe that the patients will kind of continue to drive this paternalistic model, like some trained person who's maybe 5 years younger than me telling me like what's right or wrong for me, but rather there's much more of a collaborative process. And I think the regulator will have to adopt that. Plus AI will have to allow us to also create safer outcomes by ensuring that we're not kind of straying off, but rather it keeps it more of like a binary, is this or is this that, versus an open-ended diagnosis.
I mean, I think it's the only way that you're going to get away from this horribly expensive, horribly inefficient model that we currently have, right? Like building gigantic hospitals is so inefficient. Building clinics is also so inefficient, right? Like we looked at this in our digital medicine work. In a traditional clinic environment, it takes you around 12 months to achieve blood pressure control because you're only seeing your doctor twice. You have 2 samples in 12 months. In a digital medicine environment, we achieve optimal blood pressure control in about a month and a half. That's a 10x change. Not a single doctor involved. It's all, well, there's doctors involved in the initial prescription of it, but the actual titration of the medicines dependent upon algorithms, which are well described in the literature and overseen by clinical pharmacists. And the patients then take their blood pressure 2 or 3 times a week, adjust their medicine every week for 6 weeks. And you can just quickly infer how quickly you're going to reach control of that. Same data with diabetes. And by the way, it works even better the further you are from a big medical center and the lower your income is. Because then you actually can do it on your free schedule, right? If I'm working 2 jobs, it's easier for me to engage on my phone, grab my blood pressure on my break, and then adjust my pills based off of some messages that I got from my team, than it is for me to like try to figure out a way to squeeze 2 hours of my day to go see my doctor every 2 weeks. So there's data that we published on equity that shows that, for Medicaid patients and patients that are working a shift work, it's easier to do this kind of care and even more efficacious than people who aren't.
Much more likely that they'll actually find the time and prioritize it in their busy day to do it. Jason, you've laid such a good blueprint for, first of all, how to drive innovation from the top down, from the bottom up, connect the dots by solving the right problem, having the right workflow, coupled by the right vision. You've talked to us about how we have to find ways to engage patients in a different way and really make them part of the solution and move away from a more paternalistic, maybe more transactional model that is extremely expensive and just unsustainable given people are living longer, aging population, tax base isn't growing. What's the call to action behind all this? Maybe let's start with the technology community. A lot of digital tech, a lot of medtech entrepreneurs listen to this podcast. What do they need to do differently? How can they help to bring on this transformation?
So what I often tell, and I work with a lot of smaller stage companies and seed companies, stage Series A, B companies and startups. And I love working with startups. I love it. It's so much fun and so much energy there. And I think the problem that I've seen is that on the tech side, there tends to be a fair bit of hubris. And I think like that tends to be, and not excluding healthcare too. In healthcare, there's also a fair bit of hubris. Being able to explore together and figure out what the right problem is and be open to understanding about like how we can shift models of care and shift established thinking. From the tech side, it's thinking if you throw money at the problem, it gets better. From the healthcare side, it's thinking, well, if you throw doctors and nurses at the problem, it gets better, right? So how do we find that place where we can be innovative? And then I think the other thing that people have to think through, the call to action, is you need to think about scale. We have a lot of people working in a lot of small problems. I think one of the things that I feel like other countries do well that the United States doesn't always do well is you throw a lot of people and thinking about it one big problem. You can get a bunch of people kind of coming up with a problem that scales. And instead of having 40 startups, each with little tiny pieces of that, right? How can you create linkages between those different companies so that they can then work together to solve a different piece of the same puzzle and collaborate in that way? Instead of like trying one, take the whole thing from a company, we're trying to two, take one little piece and the rest of it falls apart. So that's where I act a lot as an aggregator for bringing other startups together. So I'll say this startup here. Yeah. And I'll say this startup here and Epic here. Why don't we all talk and we figure out how to do this problem together? And then we figure out ways that each of us can stay in our lane and remain financially viable, but at the same time, try to fix the bigger problem. I think startups get really nervous when you do that because they worry about IP and they worry about their moat and they worry about lots of other things in software that are important to worry about. But if you give that problem a chance to work through and you're open to collaboration and open to sort of like maybe tweaking your idea and thought process on that idea, I found the companies I work with that do that are fantastic, right?
That's a great call to action. I mean, first of all, is let go of your hubris. Make sure you're really collaborating with the clinicians openly to make sure you're solving the right problem. Have that dialogue. Don't assume you know everything, and be open to iterating on that. And then once you have a problem to solve, think about how do you solve that in the context of a broader ecosystem, knowing that not one solution will solve everything, not even the almighty Epic, and knowing that like just by solving a lot of different approaches that are each kind of like little chinks in the armor, you're not going to complete the whole vision. You got to work together. So I think that's really practical for entrepreneurs to hear. What about for healthcare providers, Jason? Like what needs to be done differently to usher in this future vision? What do they need to create a chief innovation officer role in their healthcare organization?
Healthcare is going to change faster than it ever has. And there's things whenever doctors ask me about, they're like, is AI going to take my job? And I said, well, no, but doctors with AI are going to do better with doctors without AI. So as a system, we need to learn how to enable our workforce to do this. And a good example of this is ambient listening as an AI, right? So ambient listening is a technology that's just come out that's transformative. It truly is transformative. And when you ask any provider that's doing it, they're like, this has changed my life in so many good ways. But the problem is that you can't think of that when you go to your CFOs, they're like, well, I don't see doctors seeing more patients, right? How does happy doctors make our company better, right? I know I'm trying to pick on CFOs, although I like to pick on them. But I think what you have to think about is how those technologies then downstream interface and change the clinical encounter. How are we training our doctors now to have a different clinical encounter with an ambient listening than they would in a typical encounter? And there involves change in that clinical encounter with the doctor. The way that they have to do their practice is going to change fundamentally. So I think being open to change and enabling our providers to be able to say, like, this is going to change and you're going to have to get used to it because there's no choice. We have to continue to beat that drum of healthcare as it's going in the current track will financially fail our country, will financially bankrupt our country. And like anybody who's been through the healthcare system, and I have as a patient in many levels, it has failed me personally. So I think we have to realize as doctors, as healthcare providers, that there is a big call to action. We cannot continue the same pathway that we've been going on. And I think that's where, folks like me who have been both a doctor and a patient and also an engineer can see it from lots of different viewpoints and to help communicate to my clinical colleagues, like, it's okay. Like the sky's not gonna fall, but we're gonna have to move with the times, and the pace of change is faster now than it has really ever been in medicine, and maybe in our society at large.
I love that. I think, Jason, truly you're one of the unique individuals that can connect the big picture vision and the conviction that we have to change and we must, and here's how we're going to do it, to the practicalities. You have such good real life examples that were, I'm sure with all these success stories you've shared, you've had a lot of failures and obviously you've got a lot of battle scars. So you know how to do this. And I think we really need more people like you that can do it from the top down and from the bottom up, because it's where the meeting of the two, the clinical and the innovation, the strategy and the execution, that's where we're going to fundamentally see this. And it's going to be industry and providers working together hand in hand on that. Such a fascinating talk today. Before we close things out, if our audience want to learn more about you, what you do, what you say, how can they get in touch with you? Where can they follow you on social media?
So I'm not a huge social media guy. I do not even have a Facebook page. But you can definitely follow me on LinkedIn. I post a lot of stuff on there. Also repost a lot of things. So Jason Hill, Ochsner, if you put that in LinkedIn, you'll find me. Ochsner. Happy to also have some discourse on it. I do discourse on X and other platforms as well occasionally, but mostly through LinkedIn. And then also at Ochsner and folks from my team will be at Health and Vive. So I'm happy to have in-person conversations with people, in the IRL, as the kids call it nowadays. And so you can see my profile there. I spoke at Health last year. I'm going to be speaking at HIMSS this year. So happy to meet folks there as well.
Wow, such a pleasure to connect with you. You've gotten me really excited about the future of healthcare. That's all we have time for today. So to you, Jason, thank you very, very much. And to our audience, please follow us for the next episode of our podcast. That's a wrap.
Thanks, Ohad. Great. And thank you so much for having me on. I really, really appreciate it.